Good afternoon, everybody. Thanks for joining. We're just going to give another couple minutes for people to join. If you are a committee member, if you would please put your name in the chat. If you are a committee member who is on the phone, please unmute and let us know that you are here. We should be getting started in just a few moments. Thank you.
Right. Everyone will be starting in just a minute. Sharon, when we have quorum, if you want to let me know, just put in the chat or let me know, either way.
We do have a quorum, Jesse, so you can begin. Thank you.
Great. Well, welcome everybody to the August Medicaid Advisory Committee. My name is Jessie Mandel. This is my last meeting, my actual last meeting as chair, unlike last meeting where I said it was my last meeting, it wasn't. So it's great to see everybody, and I hope everybody's having a good summer. So we're going to just kick it off with approving the minutes, and then we'll talk more about some of the open seats. So for members who are here, here are the minutes, and when you are ready, I'll take a motion to either make some changes or approve the minutes as they are. Would any member like to approve the minutes or make any changes to the minutes from our July meeting? If not, we can maybe hold off on the minute approval until members have some time, if you need more time to look them over and come back to this on the agenda, unless anybody wants to make a motion to approve the minutes, which is really just a motion to approve. You don't have to do more than that.
I'll make a motion to approve the minutes. I had a chance to review them. Thanks, Jesse.
Thanks, Michael. And again, if anybody didn't have a chance and would like more time, that's fine too. I definitely know that feeling. So can I get somebody to second the that motion?
Hey Jesse, this is Davis Moore. I'll second it.
Thanks, Davis, and welcome. Your second meeting and you're already making motions. That's great. So thank you so much. All right, so we have approved the minutes and from July, and this is something, actually I should just say, for new members, every meeting we do send out the meeting notes ahead of time to look through them, and there's sometimes things to change or corrections, so feel free to look at them. I know people do go back and look at them. And also for new members too, I just want to mention that we record every meeting and it's available on the Medicaid Advisory Committee website. So if you ever want to go back and listen to the meeting, I know that sounds very exciting, but sometimes it's helpful to go back and listen to a recording or part of the meeting. So those are also available on the Medicaid Advisory Committee website. And we do actually, I should mention too, that occasionally we'll even have reporters or other people listen in. So just these are open meetings. So just be aware of that as well. But your participation should not be hindered by that. So with that, I'll continue on. We have some open seats that we will be looking to fill in September. And that will be, thanks so much, Sharon. That will be my seat, the consumer advocate position, but it falls into the general consumer category. So we will be looking for Medicaid beneficiaries first, and then opening it up to to and non-governmental or other consumer advocate seats. Christine Evans is also up. Christine Evans has been you've been really great. It's been really great to have you on the MAC. So you'll be missed. And so we
Thank
will.
you.
Yeah, thanks.
Hey, can I ask a question too?
Yeah.
Do you have there's a little list I can forward on to see if anyone else would be interested in any of those other positions?
Yeah. Oh, you mean all the open positions and what they are?
Yeah.
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 We can send that to you. Thanks, Christine. Christine, so this is your terming off, so you've been on it for 6 years too, just like I have. So yeah.
Yep. Second term.
Yeah. Thanks so much. Great. Yeah, so we will send that out if anybody else wants to have a list of the open seats. I know thinking it was my last meeting last month, I did go off on kind of a spiel about the importance of the process overall. And I think as Michael gets, in his chair role, we'll also be looking, I hope, at the nomination process and how that goes through the sort of DHS channels, especially in the new merged department. So, but the priority really is to have beneficiaries participate on the MAC. And so the more that we can help get the word out, not only on the Wasatch Front, but throughout the state, that's going to be really important. And real fast, since we still have just a minute or two left, I do want to, I know that Davis, I can see you. Hello, you were introduced last time. We also have Lisa here too. Lisa, I don't want to put you on the spot, but you are our newest MAC member. Welcome. And it's great to have you. Do you want to introduce yourself real fast to the committee?
Sure. My name is Lisa Heaton. I'm the executive director of House of Hope. Been here for about 23 years and know some of you and look forward to helping how I can.
Great. Thank you so much. Great to have you. So great. Thank you so much, Lisa. And I just want to say too, since this is, since I will be leaving the MAC, it's been a real honor to be able to chair this committee. I think I was put in this position by default since I don't think anybody else was eligible at the time, but it has been a real honor to be here. And I have so much appreciation for everybody on this committee and for showing up and participating. And I think we all share a mutual love for the Medicaid program and also a desire to continue to make it stronger and more accountable, transparent, equitable. And so I look forward to continuing to do that from, with my camera turned off and in the peanut gallery and joining other fine past co-chairs in that role and look forward to the work that the committee will continue to do. And also, I just want to express appreciation for the Medicaid department and division and the great folks there, because you all do really incredible work every day. And, it's not easy, we know that, but we are really grateful for the work that you do. So thanks. And with that, I will move on to our second agenda item. Stephanie, yeah.
Hi, Jesse. I will send you'll have a note from me later, but I did just want to say that I just appreciate so much the advocacy that you've done for so many years on behalf of Medicaid members, and it just means a lot, and I'm going to get emotional, but anyway, you're at one of the first meetings I ever came to, and you've always helped me feel like my voice was important, and I just really appreciate and value that about you. So thank you for all that you've done. It really does mean a lot.
Thanks, Steph. I feel really lucky to get to work with you. So thanks so much for saying that. Okay, well, thanks. And thanks. Thank you. All right, so moving on to the National 988 Crisis Line. We have a presentation about that. So I'll turn it over to Brent and Nicole if they are here to do that presentation.
So Jesse, I don't see either of them on the attendee list, so perhaps we can just go to the next agenda item.
That sounds good. And when they hop on, we can just rearrange the agenda. Sounds good. Thanks, Sharon. All right, Jennifer, do you want to give an update or some information following up on what Jennifer Marchant to what we talked about at the last meeting?
There we go. Can you hear me?
Yeah.
Okay, so will I be presenting after Nicole and Brent?
So you were, but they aren't here yet. So
Oh.
if you wouldn't mind, sorry, we're going a little out of order. If you're able to present now, that's great. If not, we can also go towards the committee member updates. But if you're able to present now, then we'll go to you next on the agenda.
Oh no, I can present now. No, that's fine. Yeah, I was preparing to speak after Nicole and Brent. They were going to speak about the new National 988 crisis line, and my presentation is kind of like, it's not a follow-up on that, but it's kind of in the same subject. So regardless, yeah, I can give the presentation if you'd like.
That would be great. Yeah. Why don't you do that, and we can always backtrack. I think if you are able to just quickly say what the 988 crisis line is too, that would probably be helpful as well for your presentation. I'm sure a lot of people here know, but that could be helpful.
Okay. Yeah, sure.
You.
Would you like me to jump in now, or?
Yeah, that'd be great.
Okay. Well, yeah, so the 988 crisis line, and I know Nicole and Brent can do a lot better than I can. This is just off the cuff. This is a crisis line that serves those with mental health needs. It's like the 911 line, and 988 just went in this summer. And so you can be connected with a lot, with people who are better trained to deal with mental health emergencies, to get you to better resources. For example, if someone having a mental health emergency, if their family member has called the police in the past, sometimes it's made matters worse, not better. Recently, when people have called 911, you can ask for a CIT officer, certified, now I can't remember the name, intervention team. Anyway, crisis intervention team. Thank you. I've actually spoke at CIT trainings and I can't remember what it stands for. So that like a police officer who has training in mental health can like go into a situation and help de-escalate it, or get someone to a hospital with the insight knowing that the person they're working with most likely needs to see a doctor, most likely needs treatment. And so it's a lot more efficient, a lot more humane. And 988 kind of is more on that level. So it just 988 streamlines you to those services. And I'll probably wait more for Nicole and Brent to go into more detail. I wasn't expecting to speak on that today, but I can go into my presentation.
No, you're great. You can, and there was a message in the chat that they're on their way. So sorry to put you on the spot to give that. Go right into your presentation.
You know, it's fine. Actually, the presentation that I'm giving kind of, like I said, it kind of follows up on that a little bit, or it's in the same subject. And the presentation that I prepared today for just inpatient hospital unit updates, speaking of 988 crisis line, and my presentation is mental health inpatient hospital unit updates. I've really tried to cram a lot of information into 10 minutes. So what I did is I put my presentation kind of into an old-fashioned format. I hope that's okay with everybody. I just kind of wrote everything out. It's nice to kind of have like an interactive presentation, but with all the content in this, I'm just going to give my presentation for 10 minutes and then have a Q&A after that. Would that be all right? Good?
Sounds great.
Okay. All right. Well, I'll get going then. Okay. Hi, everybody. My name is Jennifer Marchant, and I've been serving as the MCAC Group's behavioral health rep. I joined a couple years ago, and I've been quietly learning about how things work. Recently, I was given a new position as vice chair, so I'll be a little more actively involved. Adam Montgomery was my predecessor, and he was planning on speaking today. However, I'm going to fill in for him, and hopefully he can follow up with the MCAC in the future. In late July, Adam addressed some concerns that he was seeing in some inpatient behavioral health settings. And although this issue is much more broader than Medicaid, it can and does affect behavioral and mental health Medicaid recipients in some inpatient hospital settings. Adam and I are CPSs. It is CPSS, that stands for Certified Peer Support Specialists in behavioral and mental health. Some people describe us as patient advocates. We take our knowledge of having the lived experience of mental health conditions and we advocate for those receiving mental health services. We act not just as advocates, but often as teachers, support group facilitators, hospital workers, legislative advocates, veteran supports, and in my humble words, perhaps sometimes diplomats and cross-cultural communicators, or we try to. Hopefully our work and or volunteer advocacy is seen as building bridges. I call Adam the canary in the coal mine for protecting everyone from backsliding into the old days, the old decades and centuries gone by of institutionalization. And by everyone, I define all of us, clients, patients, doctors, nurses, everyone who works in healthcare. As all of us know, unfortunately, mental health hospitals in previous decades and centuries were not pleasant places. They are now subject matter, for example, for horror movies, Halloween haunted houses, and those remnants and memories can still permeate well into modern day thought and vocabulary, despite all the massive changes for the better. It's concerning because an individual in need of mental health services or even hospitalization may be too scared to seek treatment because of that history. And that's understandable. Today, it is a much different and better world than that of centuries gone by, but it does take vigilance and action to keep ourselves up to date and help others understand the facts. I think recently of a local medical doctor who unfortunately took his own life in 2021. He was suffering from depression and he was burnt out on account of the pandemic. Additionally, over the summer, I heard the last part of a news broadcast, either revisiting this story or raising awareness about another doctor who had taken his life. This doctor's health insurance benefits for mental health only allowed him to see providers in the same programs in which he worked. This created a dilemma in that in seeking mental health services, he would be receiving those services essentially from coworkers and people he knew. It's only conjecture on my part, but I'm guessing that maybe he didn't want to discuss his mental health with his coworkers. Maybe he felt he needed more privacy or felt reluctant to disclose. All I know is that these losses didn't need to happen, especially to good medical doctors fighting the pandemic. There could have been other reasons for not seeking mental health treatment. CPSs like Adam and I and NAMI, the National Alliance on Mental Illness, we see those reasons all the time. Adam, who spoke in late July, has observed that in some cases, and I quote him, the authority of the clinician supersedes the needs of the client sometimes. And clients or prospective clients can see that top-down hierarchy and that high power distance. Adam also notes, and I quote, sometimes there can be a lack of empathy toward the patients. Both Adam and I understand and respect the need for professional boundaries. That's not in question at all. Medical workers, therapists, teachers, support group facilitators, we all need healthy boundaries, and I need healthy boundaries, and because I can and I have burnt out many times. However, to me at least, ideally it should not come, creating boundaries should not come at the cost of kindness to those who are suffering. Adam was seeing some additional concerns. There can be a lack of accountability in the inpatient hospital settings. in giving patients good information during treatment and upon discharge for the follow-up outpatient recovery programs. This can include peer-run programs that help people adjust to the transition of being discharged, and also reducing recidivism rates that keep people from returning to the hospital. The hospital is there if you need it, and that's wonderful. But other options can be explored to prevent unnecessary and unproductive hospital stays. That can get expensive, and that does concern Medicaid. Another of Adam's concerns is he is worried that some of the staff and nurses aren't properly trained to work in behavioral or mental health, although that many are. So this isn't everybody, just a few. Some of the nurses have stated that if patients only just modeled the behavior of the clinicians, everything would be okay. This is an unattainable standard for many patients, especially for those suffering from schizophrenia and many various forms of psychosis. Adam found this especially troubling as the nurses on the unit were expected to work without empathy or emotion. Ironically, if patients were to actually model the behavior of the nurses, they would never be considered well enough to be discharged. The patients would come across as robotic or cold, and I see some people smiling, they know what I'm talking about, unfeeling, distant, devoid of emotion, and devoid of hope. The nurses merely put on their scrubs in order to disconnect and shut themselves off from the patients who they sometimes actually look down upon. The selective process in some hospitals for nurses was, quote, an ability to focus on the role without any emotion and without any empathy. And again, we understand healthy boundaries, but if there's no empathy, how can there be trust in treatment? And this can be counterproductive in an environment of healing. While we maintain professional boundaries in all our fields, we can still smile and nod our heads, acknowledge someone's presence, compliment each other, and use voice inflection to cheer each other up. For example, great job, Joey, look at your progress, instead of just talking about someone or talking about Mr. Smith in the third person in his presence as if he wasn't even there. Adam had two final concerns. At times, he has seen clinicians in inpatient hospital settings wearing scrubs in the mental health units when it would be more appropriate to be wearing plain clothes. Now, there may be cases in which patients are being transferred back and forth to medical units, and a nurse may be wearing scrubs. That's understandable. However, when this isn't the case, it can create a fear of clinicians or create a higher than necessary power distance through vulnerable patient eyes. Adam himself has been required to wear scrubs as a CPSS worker, and that created a non-approachable boundary for patients. Plainclothes attire created an atmosphere which helped patients relax and speak with the CPSS workers, someone who had been in their own situation, who had had the lived experience. Patients do open up and disclose a lot of information that they would not necessarily disclose to a doctor when they feel safe and feel like the hospital worker has been in their own shoes. Finally, Adam's concerned with some of the practices of having a patient wear a medical gown. Again, some circumstances, some patients did have co-occurring medical conditions and were being transferred back and forth to medical units, or they were very, very high risk and were therefore required to wear a hospital gown. However, what Adam was seeing does warrant some concern. Some of the patients were being unclothed in front of staff before having their gown put on. Adam was very concerned about the patients having no clothes in front of the staff, as if they were being put on display. And that he was also worried that they were being unnecessarily dressed in a medical hospital gown, especially since it made some of the patients cry. Some patients communicated to Adam that they were very scared and afraid. This created additional problems than had already existed, in that the negative experience with the hospital gown was creating its own symptoms and behavior, in addition to the original ones that the patient had originally presented with. Adam also expressed concerns that the patient experience was not being considered as valid because they were only labeled as being quote unquote sick. I quote Adam, "One goes into the hospital and has procedures done on them, and they become well due to the authority of others." In my words, it sounds like maybe a prescriptive environment, only without any descriptive feedback from the patient. For example, this is the reality of how this particular treatment helps me or hurts me, because every patient is different. In closing, kindness, connection, empathy, and validation, treating each other like humans, is a matter of life and death for the patients and for those seeking care or thinking about seeking care, including medical doctors. Knowing that there is hope brings back the light in people's eyes. And again, I want to repeat, it is a two-way street with treating our medical doctors with kindness and empathy during this pandemic. I do want to highlight a new book from a University of Utah psychologist titled The Burned Out Physician by Joseph Allen, PhD. Perhaps this can be a resource for physicians who are struggling and others working in healthcare and have been working in healthcare during the pandemic. I thank you all for listening and for what I compacted into 10 minutes or tried to. I hope I will be able to learn additional things as both the new vice chair and a consumer representative. For 14 years, I've worked and volunteered with organizations such as NAMI, the Office of Substance Use and Mental Health, and in legislative advocacy in helping consumers find their voice, not just in medical care, but in health insurance matters, and finding hope for recovery in the future. Thank you for your time.
Thank you, Jennifer. I have a question. Thank you for the presentation, and thank you to Adam for his support in the presentation too. I'm curious about whether this is something that that you and other certified peer support specialists have talked to some of the industry associations, like the hospital association or the medical association. I just wonder about those types of organized, that's an organized group that if they heard that, I could imagine that they could make a lot of use of this presentation, especially the hospital association, for example. I mean, it seems like some of those things are things that are decisions made by hospital executives. So I just wonder about whether that's something you all have done, or yeah, I guess I was just trying to think about there's people on this call that are a part of the hospital association that could connect you to how that could happen. I guess that was just something I was trying to think about too.
And I've entered this presentation we've talked about with other organizations, and Adam has gone up the chain to those running the hospital in which he found the concerns. Sometimes it can get kind of complex, and like I said, we try to be diplomats, and there is a lot of cross-cultural communication that goes on in seeing everybody's point of view on a matter. My presentation isn't meant to be accusatory at all. It's just to just open up communication channels, and that we all understand each other well to the best of our ability. So Adam will be presenting, he already has actually, to quite a few other groups, but he will be doing that presentation to other people. If you know of anybody who could help on this matter, please send that information our way, and we would love to talk with them.
Michael, is there a hospital association representative on here that could, or sorry, go ahead, Andrew.
Andrew, I think your mic is off.
It it just took me a second to turn it on. I was just going to tell Steph to go ahead and finish her thought.
Yeah, I just wondered, like, Michael, if you have ideas for how she could connect this to just trying to respect their time too, of like if this got presented to like a convened group at the hospital association, if that would be a good use of their time.
Yeah, and whether it's across the board, all hospitals in the state issue or specific hospital issue, I think if you think it's more related to a specific hospital, in addition to the administrator of the hospital, usually a hospital will have a community board of directors that are interested in how the hospital is interfacing with the community as a possible. But I will definitely take this back as the hospital representative on the MAC to our Medicaid program task force that deals with Medicaid issues within the hospital association. Not specifically a Medicaid specific issue as we acknowledge, but just try to raise some awareness. And I know that behavioral health issues are very important to Greg Bell, who's the executive director of the hospital association, and see what discussions can be convened. So that's what my action plan is, Stephanie, but thank you for thinking of me.
Thank you.
Jennifer, I know you've heard about and been following closely the work that the hospital association has been doing around their mental health study, but I think sharing this information specifically with the folks involved in those discussions would be extremely helpful.
Okay, that would be great.
Thank you, Jennifer, so much for sharing that, and to Adam too for both of you for putting this presentation together. And also, I really just appreciate you sharing a little bit about your background too. I realized, when you joined the MAC, it was, it's helpful for us to continue to hear about all the work that you're doing. So thanks for sharing that.
Thank you.
Hopefully this is the start of more updates to come. But I agree, and also thanks for sharing a little bit at 988 when I put you on the spot. But I think
are Nicole and Brent here?
Yeah, they're here, and I think that's actually I see Nicole here. Nicole, thanks. We're going to turn over you to give a update on 988, but hopefully you caught a little bit of that presentation too, because I do see that connection. I think that's also something that will be really helpful to keep those that open communication going as 988 rolls out, to be aware of what some of the issues that Jennifer flagged too. So with that, Nicole, I'll turn it over to you. Thanks for coming to give a presentation.
Okay, absolutely. I see a lot of friendly faces on today's call. So some of you may have been privy to this presentation in the past, but I'd really love to be able to just give a quick update on where we are, where we're going, and an overview of 988 for people that this may be a relatively new concept for. So it sounds like there has been some questions on it already. So as you know, on July 16th, 2022, the 10-digit National Suicide Prevention Lifeline 1-800-273-TALK transitioned to the 3-digit Suicide in Crisis Lifeline. So not only opening the door for really an easy, ubiquitous number for people to be able to access in times of emotional distress and suicidal crisis, but just crisis in general, to include behavioral disruptions and also substance use related crises as well. So of course, right, this has been heralded as an opportunity of a lifetime for not even just the crisis system, but for the front door of behavioral health for many individuals, as well as the larger behavioral health system. So we, like our partners at SAMHSA, are incredibly excited for the opportunity that 988 will continue to bring in decades coming forward. So how does 988 work? I get a lot of questions on what exactly is the difference between 988 and the number that we've historically used within Utah as our Utah State Crisis number, the 1-800-273-TALK number. So we'll talk a little bit about what this exactly is, right? So if you were to dial that 273-TALK number, or beginning on July 16th, that 988 number, what would have happened is you would have been routed into a network of call centers across the country that made up what was then the National Suicide Prevention Lifeline Network, and is now the 988 Suicide and Crisis Network, right? So at that point, you would hear a brief recording where they would offer you an option to press 1 for the Veterans Crisis Line, or press 2 for the Spanish subnetwork. At that point, based on your area code, you're routed to the crisis center that is closest to you. So here in Utah, that's the Utah Crisis Line, as operated by Huntsman Mental Health Institute. And there you'd be met with really a qualified and competent crisis worker who attempt to stabilize you and offer you support, and really de-escalate the crisis and provide you emotional really support in a time of distress or need. Really, ideally, we want to see, or we oftentimes see, about a 90% stabilization of all callers into the crisis line. But sometimes, really, people do require additional resources. So that may look like somebody to talk to in person, right? Maybe you need somebody to respond to your home. So perhaps like a mobile crisis outreach team would be indicated, a team of a therapist and a peer support specialist if possible. Or perhaps really for some other individuals, they really need a safe place to go for additional support. So that's the role of a zero refusal receiving center, or a crisis center in terms of the stabilization continuum. So truly, really, 988 is only the front door or the first point within a crisis continuum. So some fast facts about 988 and what it represents. For sure, it's available here in Utah and will continue to be available here in Utah. And beginning on July 16th, it became the main way to access our crisis line here in Utah, as well as across the country. We are aligned with our national partners on that. But that doesn't mean that our current crisis numbers won't work anymore. So for instance, if you call that 1-800-273-TALK number, or any of our historical legacy numbers here in Utah, they will continue to work and continue the route the way that they've always routed. This line, of course, it's 24/7 and available 365 days a year. And our primary goal for this first year will be to provide this individualized and very customizable response for people over the phone, and of course, right, building those connections to community resources when needed. But we're kind of really still in kind of the build-up for this program. We know that crisis hotlines save lives, and we are incredibly excited for the opportunities that this system will bring. But for right now, really, our primary intention is really focusing on capacity building for 988, and also those bridging connections to additional community supports, to give somebody who's in crisis a safe person to talk to, a safe person to respond, and a safe place to go or stabilize whenever possible. So are we ready for 988 here, or were we ready when it launched? And the big picture is that we've been preparing for 988 in some context or another for over a decade. We've demonstrated to our statewide and national partners and constituents that we have an investment in protecting the emotional well-being and health of our Utahns, but also that suicide prevention and crisis intervention is really a priority here. So we're going to continue on that. Many people know, but 988 actually kind of started in Utah, strangely enough. We attempted to create a 3-digit number back in 2015 that resulted in a continuing resolution that created essentially the National Suicide Prevention Lifeline Improvement Act, which then created the National Suicide Hotline Designation Act. So really kind of a landmark for Utah. So our long-term vision, right, is not just that capacity to respond over the phone, but it is to build out this comprehensive crisis care system. And we know that that's going to take time. Competent, but it's really being designed that we provide people better, more sensitive care. We keep people out of emergency rooms and inpatient hospitalizations if that's not the right level of care and if it's safe to keep them in the communities. And we divert from law enforcement and jails whenever possible. And the key elements of that crisis continuum, of course, if we were to think of this as a funnel, the most contacts will be managed by the crisis line. And then, of course, right, crisis line refers into our mobile crisis outreach teams, and then, or our stabilization facilities. But theoretically, mobile crisis outreach teams would be a direct referral for our facility-based crisis system to include receiving centers or subacute hospitalization units. So here in Utah, we have a wide variety of resources. This is a very busy map, but it is just a true picture of the different pieces and components of our crisis system that are both directly associated with our programming, but also some that are extensions of us, right? So ACT and Bridge or MOU or MOD programming, crisis intervention teams, where we really partner with law enforcement to, essentially when law enforcement is called, that they're providing a more sensitive and more competent response to their communities as well. So what's the difference between 988 and other resources like 211 and 911? The key consideration is, right, between 911 and 988, which is oftentimes the most common comparisons, they're truly unique systems with unique needs and strong collaboration. So 911 really represents the front end for people who are hurt or in danger, but it's really an important part of our public safety and emergency medical response and disaster preparedness. While 988 really gives you access to a qualified crisis counselor who is going to provide support and counseling and interventions for your behavioral health needs that may be urgent. It may provide support in distress, but we really do see this as an integral tool to help reduce sentinel events such as suicides and overdoses. Essentially, right, 988 and 911 have to be included, but within the continuum of front-end resources, and this is not inclusive of all of them, right? But like 211 really is quality of life, like essentially access issues, right? IHC and like the behavioral health network operated by IHC is a fantastic, really kind of warm line to be able to get connection to different various mental health providers. We know our care system can be somewhat complex, so we're in close coordination with them in developing 988. In terms of like what we would consider really things that are not, in the red just yet, but really concerning or distressing and really needing crisis stabilization, we have 988, or like another resource here is of course our Safe UT, our text and chat app for not only youth in crisis, but now of course with a Safe UT Frontline and of course a Safe UT National Guard, but a wide continuum. And then of course really reserving 911 for public safety, emergency, medical emergencies and disasters. So our current goals and objectives, right? Of course, we want to ensure our number one goal this next year is to be able to meet the demand for 988 calls, and then as a center begin to accept texts and chats. And we hope to be able to do that within the next quarter to half year. And then the next component, right, our secondary goal is, of course, right, these systems take money. They're a vital emergency response system. But our goal, of course, is to continue to work on securing, stabilizing funding and in leveraging resources and payers whenever possible, but ensuring that this is as an essential service when people contact the crisis line and corresponding crisis resources, they're not incurring costs whenever possible. So MCACs and receiving centers, et cetera. And then our third goal is to really build on 988 here, knowing that we really want to answer as many calls and support our national partners and backup networks. But we also want to, give Utahns here the linkages that they truly need to really stabilize their crisis. So, you know, we have a couple of different arms of this initiative. Of course, we need a workforce to develop, right? So we need people to respond to crises. We need to educate stakeholders like yourselves and community partners on the crisis system and the purposes of it, and also review standards and make sure that we're in line with best practices, and then really strategic passive marketing and essentially getting the word out about 988 and what it means for Utah. So over the next several years, over the next 5 years, we really do hope to have a fully functioning continuum where 80 to 100% of people have someone to call, someone to respond, and somewhere to go, or someone to stabilize. So you'll see a bit of a titrated response here, building up to really this fully functioning system. So are you and your organizations ready for 980? There are some things that you can consider, right? So one of this is that, do you have a relationship with your state crisis center? Are you familiar with their various lines of programming? I know that my partners at HMHI and myself are really open doors, and we're happy to engage in any conversation and provide additional support. Really do accept individuals in your office or your practice or your partners from crisis in real time. There are a series of best practices, SAMHSA national guidelines to include really trauma-informed approaches, the addressing of recovery needs, even in physical health type settings, utilizing various frameworks or standardized tools like the Zero Suicide Framework or a standardized suicide screener or risk assessment such as the CSSRS or SafeSide. And then also, are you considering social determinants of health within your practice, and also practicing cultural competence and humility. In terms of gauging operational readiness, right? One, to take a look at access for sure. Another thing that we want to be able to take a look at is capacity. So not today, but building towards it. Are you able to accept urgent appointments or routine appointments from individuals in crisis, knowing this is a long-term project? These are some of the things that you can evaluate. What would it look like if an operator or somebody from the crisis center reached out to your organization with a consumer who was stabilized but was recently in crisis? What could your organization help with? The other piece is, I think, something that you could do right now. So updating voicemails, like voicemail messages. So if you're having an emotional or suicidal crisis, being able to say call 988, a little bit easier to remember than the 10-digit number. Some messages, email threads, right? Websites and safety plans, and transitioning over to that 988 number from the 10-digit number. And then, you know, internally for your own operational readiness is, have you considered standardized approaches for individuals who are experiencing crisis? And I'd be happy to offer some TA for individuals who might be interested in that. Some additional considerations. We do have a talking point document that could be very helpful. We'll make sure that you get that after today. Any kind of passive marketing, like, you know, printed materials, magnets, etc., updating word of mouth, that's perfectly fine. Go ahead and get the word out about 988. If you're going to do like a media blitz or like a television campaign, or we consider active marketing, please just let us know. We want to work to ensure that we have capacity here in Utah, and also not only for Utah's Crisis Center, but also our national partners who act as our backups. Here are some helpful links that will be included in the slideshow that I'm sure could be sent out to you. Some fantastic implementation guides, of course, our partners here at Live On Utah, our community crisis intervention page, which has a fantastic dashboard. You can have a real-time look of the past month or so of what's happening in terms of how many crisis calls are we getting here in our state, how many MCAC deployments are being made, etc. So really kind of cool to get in there and see what's happening in our crisis sphere. As a reminder, 988 is just the beginning. We know that this will take time. We're building out a system, but we appreciate any partnership that you can offer, and I'd be happy to answer any questions. This is my contact information and my work cell phone, and you can definitely contact me whenever you need anything. So Sure. Jesse, are we okay to take questions?
Yeah, and there's one in the chat too. You probably see that.
Okay, awesome. I see, Andrew, if you want, I'll go ahead and we'll talk with you and I'll read up on the question in the chat next.
Great.
Sure.
Thanks for this, Nicole. It's really helpful. I have 2 questions for you, if you don't mind. And that number one is, you mentioned that the suicide prevention line had a separate or an independent way to handle Spanish speaking calls, but you didn't specifically reference that related to 988. So I was wondering if you could talk for a minute about the best way to handle or how to refer non-English speaking folks who need help.
Sure. I think that's an excellent question, Andrew, and thank you for clarifying that. So number 2 will connect you to a set of actual national suicide and crisis lifeline centers that have Spanish speakers. So they'll essentially be available to access the same support and resources, et cetera, but be able to speak with somebody with native-like fluency. Now, for individuals who English or Spanish is not their predominant language or their language that they utilize, the entire network does have access to translation type services or translation phone services. We understand that these are not adequate, especially for people in crisis, and they don't necessarily always cover or offer, competent care for the subtle nuances, right, that we know people have in language and culture in times of crisis. And that is something I think in terms of our national partners and here in Utah, we'll see continue to build, to be able to really expand on that. I know that in terms of federal discussions, they're really actively working not only for calls, but text and chats to not just have English and Spanish, but an additional five languages within the next year or 2. So a work in progress for sure, but we'll continue to do everything we can to create as much competence and be aware that we're not there yet. We're working towards it.
So just to clarify, non-English speaker Utah callers may not have their call answered by somebody, answered or responded to by somebody at uni, but more likely from one of the national backup centers or something like that.
That is correct. I do want to say that Utah, our crisis line does maintain Spanish speakers. So if one was available here, now within the last several months, what we have seen our national partners develop is what's called a unified platform. So for instance, if somebody was needing additional support and was not able to be stabilized over the phone, there's a pretty good chance that if they were transferred into Utah, that we would be able to help them. The thing is we don't necessarily here in Utah have the volume of Spanish speakers or like the capacity to be able to be like essentially a part of the Spanish sub-network. We just don't have the workforce as much as we would really love to, but we're limited. But we do have Spanish speakers and Spanish MCACs in parts of the state. We're working towards that, being able to expand on that and then probably the next 2 years as well. Okay.
And then just very quickly, a related question and then a completely different question for you. How about ASL capacity?
Sure.
Sign Language.
So ASL is not currently available, but it is a priority, and that's one that I think we'll likely see within the next year, being able to access through the national network. Internally, I know Andrew, that you may have worked with my counterpart, Carol Rudell and Brad as well, right? We're struggling a little bit in terms of accessing ASL coverage here, but it remains a priority as well. But I think our national partners will be able to create a third option within the next year, and be able to access that by text and chat. So
are you able to interface with 711 in the meantime?
That's the hope, and I think we can do. Of course, right? They are our crisis line partners, right? They have to be familiar with that resource themselves. But in the interim, we try to be as responsive as we can. So.
And then the last question I have for you, and I promise it's the last one. When you talk about building out the crisis continuum, how are you envisioning that continuum, and where are you thinking we're doing pretty well right now, and where are you thinking we need to put in some time and effort along various points of that continuum?
Yeah, those are great questions. And so I think that right now we're doing a really great job in terms of securing a breadth of MCAC coverage. And, so for instance, we have MCAC coverage or mobile crisis outreach team coverage available in some faction of the state, statewide. However, what we don't have is depth, right? So, oftentimes much of the state is covered. So for instance, especially in rural areas, there may be one team of 2 people covering, for instance, three counties. So the response, if that team's occupied, could be several hours before they could get to you. And so our priority this year is, of course, continuing to secure that MCAC coverage, and then build the additional layers, providing, we of course have the financial support for that. So that's our number 2 priority. And our number 3 is, of course, beginning to again build out some of that facility-based stabilization and community-based stabilization for providers. So those would be our serviceable gaps. Another area for growth and opportunity is, as you've alluded to, Andrew, is cultural and linguistic competency here within Utah is an area that I think that we could improve on as well.
Thank you very much for putting up with me for so long.
Andrew, you have my email. Feel free to take that down and contact me. I'm happy to continue the discussion. Always enjoy your questions. So
will do. Thanks so much.
All right, no problem. Just a quick question for Alan. If I observe a person who appears to be in a mental health crisis, do I call 911 or 988? I would suggest, especially if it's a family member or a friend or somebody that you know, to call 988. And then if there is no significant danger or risk, that person doesn't appear to be a harm to themselves or in others, and that can be really hard to do if you're just observing from the sidelines. But it may be helpful to be able to just contact 988 and just describe the circumstances of what you're seeing and be able to get some helpful next steps. That is an area that they're quite confident in. So again, right, that immediate assessment for safety, is this someone that you know or love or that you're familiar with? And then, of course, right, being able to just call and ask some questions is always an option as well. Great question, Alan. All right, and then I think there's one more hand up, Stephanie.
Yes, thank you for this. And I apologize if I missed this. I was trying to take notes, but I don't think I did a great job catching everything. Did you talk about like data, like privacy and like data collection stuff? Or, and if so, can you just kind of touch on what is like the data protection, and like how does this connect into like other systems? So is it going to like share data with like other parts of the government or like other parts of like healthcare, and just trying to understand that?
Yeah, sure. So the crisis line has to observe and adhere to both 42 CFR and HIPAA. I'm sure most people on the call are familiar with those terms. So any data that we share with our federal partners or our statewide partners who are not within the continuum of care for the individual that we serve, of course, is really going to be de-identified aggregate data. So for instance, how many calls, essentially what are the average like handle times for that call? what is the presenting problem? What is the disposition? Like what happened after the call? But really, when I say aggregate, there is no way to trace that back to the consumers that we're calling. Now, it's really important that we are able to provide like continuity of care, and that is covered, of course, right? But still, we're incredibly sensitive that with that information. For instance, if a person would like an MCAC referral or that one is indicated, we're operating within the framework of HIPAA and 42 CFR to be able to share that with essentially community treatment providers. Now, in cases of an imminent rescue or an involuntary emergency with personnel activation, right? So if we do have to interfere where we're concerned that somebody is actively attempting to end their life or harm another individual, of course, we are doing everything we can to provide that de-escalated response over the phone. And in another way, really, if that is, it's incredibly rare in terms of how many calls that we get. But if we do have to call 911 or use EMS, we're doing that in a trauma-informed and sensitive way. And we do reserve that for the most substantial risk for the consumer or their loved one or somebody that is calling in. Does that help, Stephanie?
Yes, I guess just a quick follow-up. If it's longer, I can just email it to you. But so when you say that there is the continuum of care and like in crisis can just be, I mean, even there's like a lot of words that mean different things to different people. So just thinking about like, so in sharing some of that like data, like what type of would the person that is in crisis, let's say a week after they interacted with this system, be able to easily remove all of the information that was pulled, that was like any of the data collected on them in that interaction? Would they be able to pull it from the system? Like, is it something that they can opt out of like a week later? Just thinking about like domestic violence survivors. I'm just thinking about people that are just like gonna really struggle with like trust if they find out later that this is like, I just think data is gonna just continually be an issue. So I'm just trying to understand some of that.
Yeah, and a person, for instance, right, you're right, crisis means a lot of different things to a lot of people. And we would never disclose someone's information. Again, right, that data information is de-identified and aggregate. So there is no necessarily way for a person to be able to access really, the broad level data. Now, in terms of, like for instance, a survivor or someone that, again, these are bound by the same regulations and laws as a HIPAA and 42 CFR. So, but a person can essentially request that their record does remain sealed, but they can work with Huntsman Mental Health Institute to be able to essentially, contact them and with any concerns that they may have. In terms of like pulling out of sealing their record, essentially they, of course, right, they would have to work with our contractor to do that, who is a healthcare provider. There may even be a representative from Huntsman Mental Health Institute here. So Stephanie, I hear your concerns and I would love to be able to continue this conversation. And if you'd like, please email me. We'll set up some time to discuss your concerns. They're valid. And I want to make sure that we're sensitive to them. All right. Well, thank you so much, Jesse, for the opportunity. Please, everyone, just reach out with any questions. So,
well, there was Alan had a follow-up question in the chat. Yeah, he just.
I didn't. Yeah, I didn't see that. What I would say, Alan, is it really depends on risk, right? So, for instance, right, it's hard for me to be able to dictate whether there is substantial risk to a person or a community based on there's that concern. But one of the things I would say is call 988 if you're not concerned about the risk for that individual or for the public. So for instance, if you see somebody that appears to be responding to internal stimuli while in distress, right? You know, perhaps like they might be upset or agitated, give 988 a call, right? And just be able to talk with that team. They may be able to offer an outreach or be able to send an MCAC team out to that consumer. Of course, they'll attempt to engage the individual for consent when they arrive. But again, it will allow somebody who isn't a law enforcement officer who has specialized training in severe mental illness or substance use to provide that individual crisis response. So again, it's a little bit more of a nuanced question, and we can talk a little bit more offline about some of the circumstances, but all right, cool. Thank you. I saw that. Perfect. Thanks. All right. So Jesse, if there's anything else, please feel free to let me know. I'll happy to come back anytime. So.
Great. Thanks so much, Nicole.
No problem.
All right. Thanks for that presentation, and thanks for Jennifer's presentation already. So now we do have some time for any committee member updates or questions. Yes, I think that's where we are on the agenda. Great. So if we do, this is something we have every meeting, just some space or time if there's any committee member updates or questions, or any questions from the public too that people want to flag at this time. So just want to put that out there if there's any questions. Stephanie.
You said committee member updates, is that right?
Yeah.
Okay. I don't know if this would belong better later, but I just have had a couple interactions with other Medicaid members in the last couple of days, including just this morning, where they're putting off care because they don't understand if they're going to eventually lose coverage when the PHE ends, and they don't want to be charged for like getting care while they may not be paying their spend down or their premium. And so they're like, am I actually supposed to be using am I supposed to be accessing healthcare, or am I going to get in trouble? And anyway, it was just as I have had the conversations, it has just reminded me that I think there's just a lot of confusion and just like just a lot of misunderstandings about all of that. And so I just wanted to share that for anyone that would like to do that, that information, what they would like to. But I think that just like still having a lot of confusion about what type of healthcare someone is able to access during the pandemic, just with some of the pandemic rules, has just become, it just has remained a barrier, I think, for at least quite a few people that have asked me about it. So just sharing it out for anyone that would like to use that information to help people.
Thanks. Yeah, I wonder if maybe we can talk about that more during the PHE unwinding update too, because I think I saw that there was that toolkit that went out, but I'm just wondering if maybe that would be something to talk further about, like how that messaging is working then, unless others have thoughts about that now. Okay, let's hold off on that. But thank you for flagging that, because I think that is a concern that I'm really worried about too. Are there any other updates? One question that I wanted to just throw out to the Medicaid team is, if someone has a question about reimbursement policy, what is the best way? Who should they be contacting?
Jesse, are you specifically wondering about like reimbursement as far as the cost of something and what they're getting paid, or is it more of a policy question? We do have an inbox that I can share where some of these questions are received and then they can be sent. So I'll put it into the chat.
Okay.
Okay.
Yeah, I think it's more about provider reimbursements.
Mm-hmm. And,
yeah. Yeah.
It would likely be received through like our medical policy inbox, and then it can be sent through the reimbursement team. So can I share that with you via email?
Yeah.
Is that okay? Okay.
Great. Okay. Any other questions, updates from committee members or members of the public?
I'm so sorry. I have one more.
No.
So sorry. I noticed that, is Nate still on here? When I saw that with the Office of like Constituent Services or whatever, that like part of the Department of, I'm just wondering what's going on with that part of DHHS, and like how do we get people to that? And also, how is that going to interact with like people's experiences in another agency, such as Voc Rehab, which is not in DHHS? Can we tell them to call that number and get help if they feel like they are really confused about information that they're getting from different agencies that do not align, like they don't line up, and so it's confusing them? Would that be a number that I would give them? Just try to understand how that department is going.
Hi, Stephanie. Let's get the proper contact information. So that is now under Jeff Nelson. So Constituent Services is under Jeff's team. And we can help with coordination if there are questions and help you get the right contact information if that's what you would need. Is that what you're looking for? Just getting the correct contact information?
And Jennifer, to add to that, also at the DHHS level, the customer experience office that's been created, or division, we do have the director hired for that, and they are starting to add staff to that. We're actually working with a specific constituent member issue with that new director. So that is, I think, another option. So as Jen said, there's always the Medicaid constituent services effort, and Tracy Barkley's been doing a great job on that for years and continues to perform that role. There's also this option to elevate that to the department level with Donovan Bergstrom as the new director there. And then he could also, either of those resources could help if there's an issue outside of the agency and you're interested in trying, or the individual is interested in trying to resolve an issue that involves multiple agencies.
Thank you. So then if it does involve multiple agencies, then, so if it's Medicaid specific, go through Medicaid Constituent Services, but if it's a lot of different moving pieces, that sounds like it would be for that office. Is that, Nate, what you're saying, Nate?
Yeah, I think in part. I mean, our Medicaid constituent does help if there's a Medicare issue, so especially like if there's an interaction between Medicaid and Medicare, those types of things, she can help try to help an individual navigate those waters. So that's an option that continues to be an option or two.
Okay. Okay, great. I think it goes beyond just like healthcare specifically, and it's like Voc Rehab and like other programs offered through DWS, and there's been lots of confusion from. So anyway, I think it would be, I'll send her to that office. Or should I wait until it gets more set up then, or is it fine to send somebody to that?
It's up and functioning, Donovan's
okay.
helping. And Maris, I don't know if you have a number for complaints inside or concerns within DWS, like constituent services, that you'd like to share.
Yeah, I think this one's going to be specific to Voc Rehab, which is a division outside of ESD. Stephanie, I can certainly get you a couple of phone numbers and email those out to you if that'd be helpful.
Okay. Thank you. Yeah, that would be great. And thanks for all the information, everyone. And can we get an update maybe in a few months on how that Office of Customer Experience is going and just like things y'all are learning? Because I think that's a really cool thing that is happening in the department. Thanks.
Jesse was channeling the same thought.
I agree.
Jesse, sorry, Jesse. I was just saying, I don't know if Nate might know more about how how far along in the process folks are, but customer experience. But we also got this last session the disability ombudsman, who that office is supposed to be cross program and cross department as well. So I don't know yet, Nate, if they are in a position to be staffed up and have the resources to be helpful to anybody yet or not.
I don't believe we've filled that position yet. I know that position's been posted, and I know they've conducted some interviews for that, but to my knowledge, we haven't hired anyone yet for that position. So they're in the process of filling that position, but unless something's happened the last couple of weeks, I don't believe we've filled that position yet. But it has been posted for recruitment. I know they've conducted interviews for that spot.
Thanks for the update.
And that may be another great one, that if we have Donovan come in and report in a couple months, that could be something that he could include in his update.
Okay. And Alan, do you have a question as well? I saw your hands raised.
Yeah, just a quick question. I may be either jumping the gun or missed this, but the conversation about PHE unwinding, are we thinking about that in the more general sense too for Medicaid in general? Is there an effort there to kind of reach out to folks and make sure that they have their phone numbers updated and addresses updated so they're not kicked off of Medicaid for those kinds of administrative things? I'm just wondering if there's a concerted effort, and I may have missed that conversation. If I did, I apologize.
I can respond to that one, Alan. Thanks for expressing your interest in this. And there has been quite a bit of effort aimed at the member themselves to help educate the member on what the public health emergency and the maintenance of effort, like what that means, to what those words mean, and what it means to go through unwinding, and what this means with regard to their eligibility, and also to really encourage individuals to update their address. So Jeff Nelson will be covering this under item number 7. And I think he'll touch on some of those efforts that we've done and can go into a little bit more detail. But certainly that is really our focus right now, is making sure that members are aware, and that individuals, even with its providers or community stakeholder groups, advocacy groups that are working directly with members, that they are aware too, so they can then provide this information about updating our addresses and things like that. So we've been working both with the Department of Workforce Services and our own health program representatives to really capture incoming phone calls and update addresses as we can. So I think DWS, as well as Jeff, can speak to a little bit more detail on how we're working to make sure that addresses are accurate.
Great, thank you.
Thanks, Alan. Great. Are there any other updates or questions? I think this is a really valuable part of the agenda, so no worries about multiple questions. Okay. Well, with that, then I will just briefly mention that going forward, we'll be forming 2 new subcommittees. This is something that the executive committee, the chair, has the ability to do. So these will be subcommittees that will be meeting outside of the Medicaid Advisory Committee meeting, but will be reporting back, having agenda updates on a regular basis. The first is that we did take a look at the bylaws and review those 2 years ago, and we will be forming another subcommittee to make some updates to the bylaws, to build on some of those updates we made before, reflect some of the DHS changes, and just look at some of the things around selection of new committee members. So Michael Hales will be leading up that subcommittee, and we'll be recruiting members for it, or people will be clamoring to join it, but he will be the one managing that process. So thanks, Michael, for leading up the bylaw subcommittee update process.
Thank you. And if anybody wants to participate in that subcommittee before we would bring recommendations back to the department and the committee at large, if you have the thought right now and you want to just put your name in the chat, we're happy to include or send Sharon an email during or after this meeting, and we'll include you in the subcommittee.
And Michael, correct me, can members of the public join? I think it's only MAC committee
just members of the MAC, right?
But it is actually really interesting to look at the bylaws. It gives you a sense for sort of the origins and history of the MAC and the roles and responsibilities of it. So I think it's a short-term process. It's not a huge time commitment, but it's a really interesting way to see how this committee is being shaped and evolving. So if you're interested, just to echo that, please put your name in the chat, or you can follow up with Sharon outside of the meeting. And then the next subcommittee that will be formed is called, well, for right now it's being called the Beneficiary Engagement Committee. So a lot of work has been done. And I should mention, I realized this was something that I don't know if we mentioned it, but at this time, Stephanie Burdick has been in the member at large position and has been doing a ton of work to, well, just in all ways. So Stephanie, I really appreciate all the work you've been doing at member at large. But one area that Stephanie's been doing is engaging more beneficiaries in this work. And so this subcommittee will be continuing that work and ensuring that more beneficiary voices are brought onto the MAC and more voices from across the state. And so this subcommittee will be an opportunity to have more folks get involved in that process, and will also be have a regular updates during the MAC committee meetings. So Stephanie, thank you so much for all the work you've been doing as member at large, and thanks also for agreeing to continue to do some of this work as the lead of the beneficiary engagement subcommittee. I don't know if there's anything else you want to add about that.
I'll just put my email in the chat, and if anyone wants to email me, if you know Medicaid beneficiaries that would like more opportunities for advocacy or just like to speak up about their experiences and the experiences of their peers, then just I'll put my email there, and I'll try to be good at emailing back relatively punctually. But yes, I'll just put my email in there, and thank you. That's all I have to say for right now.
Thanks, Stephanie. Thank you so much for continuing to do this work. I think you have really brought in more beneficiary voice into the MAC, and so I'm excited for the work to continue and to have that connection to the main committee. Right. Well, with that, then I think we'll turn it over to Jeff and to potentially Maurice as well to give an update on eligibility and enrollment discussions. And I know it seems like we're off schedule, but I think we'll still fit within our 4-hour allotted time slot. So thanks everybody for your patience as we're a couple minutes over our agenda. Thanks.
Well, we'll do our best we can to try and catch us up, okay? So I guess let's start with the PHE report. So here is a list. We're trying to put together an announcement or a view here for you each month to kind of show you where we are. As all of you have likely heard at this point, the public health emergency was extended yet again, another 90 days out to October 13th. We did not get a 60-day notification in the last week here, so we are not planning to unwind in the month of October. All signs are pointing to a later date and likely a new extension. And that's what we believe will occur, but we will continue to watch. And if that 60-day notice comes to us or comes shortly, we'll be talking to everybody as quickly as possible. This first chart here is just meant to show you of the Medicaid overall population, that smaller number, the light blue color there, 202.90 back. Thank you. Back in, I can't see with that little thing there. Darn it. That would have been March, April, May, June, July. There we go. Thank you. Sorry. I couldn't see it. So growing from May, June, and July there, you can see that number is continuing to increase by some few thousand each and every month of the cases that are either not completing their renewal or not working with us to remain eligible in the traditional sense, which means that we're keeping those cases open through other means, making sure that the case remains open and that the coverage continues. So that while that continues to increase, that's the risk. We're often asked, what will happen once the PHE unwinding occurs? I think the risk is that we have some population of 229,000 folks that have not been reviewed by DWS recently and are at risk of losing benefits. It does not mean that they're not eligible. It just means that they have not done their most recent review and are likely due for a review at this time. There is some percentage in there that, of course, that are not going to continue qualifying for Medicaid, and that's in there as well. If you'll scroll down for me, thanks, Sharon. We did release a partner provider toolkit. That's on our main website. If you go to the medicaid.utah.gov website, there's a couple of things that rotate through that carousel as you get on that website, and one of those talks about what's happening with the public health emergency unwinding. That takes you to a whole page dedicated specifically to the public health emergency. And with that partner toolkit, there's a series of slides there. If you're looking for any kind of messaging you want to give to Medicaid recipients or the people that you're seeing, we've got some great taglines in there that you can use. We've got some good information on keeping a similar message, if you will, with what the state is saying. So we encourage you to look at that. And if you have comments or anything on that, you can certainly do so there or pass them to me. We'll be happy to take a look at those. Additionally, coming soon, we talk a lot about the unwinding of all these rules and the public health emergency ending, what that will do to enrollment, and that's a big deal. But of course, there's some changes to the benefits. So Medicaid, outside of my area, but Medicaid is working on a new benefit document. We hope to release that, I believe, by next month, which will outline what's happening with the COVID-19 benefit flexibilities we've had to this point, and will describe what's going to continue and what will be ending at the end of the public health emergency. I know I saw a draft of that earlier, and it looks like it's going to be a very informative document to be sharing, and hopefully answer some of those questions for you. And then back to you, Alan. I think you had some questions on what we're doing right now. The message remains the same as it has been. The message is to make sure that your contact information is up to date. Those 229,000 people we were talking about earlier, we need to make sure that we can reach them when their turn is up. The fear we have, of course, is that everybody comes at once in the very first month. Hopefully that is not what occurs. We want to work with these folks over the course of the year we have to go through each case and make sure that they either are or are not eligible. If they're no longer eligible with us, to pass them to the correct place. So a lot of messaging in that vein. I think once the 60-day notification occurs, we're going to see the message change just slightly from make sure you keep your information up to date to also be aware of when your review date is. And so making sure that people can see what their review date is will be important to us. And we're working with Workforce Services to make sure that that information is readily available, which it is today. It's through your MyCase account, and we would suggest and recommend that members keep an account, if possible, up to date there as well. It's a great place to update your information and to see when your review is coming due. So with all of that, the planning continues. We hope we are really well prepared. We've had almost a year to prepare to this point in time, and we hope things go smoothly without a hitch. Knowing us, we probably will discover a couple of things that we did not think of or plan for, but we're trying to make sure we cover every avenue and to make sure that the folks that remain eligible and stay with us. So if we let me pause here and see if there are any questions on the public health emergency specifically, and then we'll jump into the enrollment data, if that's okay.
Hey, Jeff, can I ask a question about, I mean, to the point that Stephanie raised too, like how, I mean, the message is just keep using your benefits, but is there any, I know the notices committee is working on this. I'm wondering, can you speak a little bit about just the communications that have been going out, or maybe like we can distribute those letters more, just to that point as well?
I think Disneyland does this the best. You get in line for a ride and you make it down to the end of that, and then you turn the corner and you realize the line just keeps going. That's how this feels to us. We just keep turning a corner and there's another, wait and see approach. So we have sent out a couple notices to this point in time, really trying to focus on some folks that we thought the COVID-19 group is one that we wanted to make sure they understood that their benefits would end when the public health emergency ends. We have I believe 3 or 4 other notices in the wings right now. None of those will be sent until we get that 60-day notification. The first one is a general information notice that goes out to everybody to really let them know what's going on and what to expect. We've worked on that recently this week, trying to make sure that that language is up to date, that it has the right messaging to it. As a matter of fact, talking about this review date and your review might be due in March next year. That's great. What does that mean? What do you have to do? Or do you have to do anything? So trying to make sure that message is understood. So that's the first notice that everybody will get at the time the 60-day notification is released, or shortly thereafter, I should say. It's going to take us a minute to print those and to get them ready to go, et cetera. So when I say shortly, probably 2 to 3 weeks, I would guess. Shortly after that, we have some groups we focused on, those that receive spend downs or have a spend down to qualify for Medicaid. We want to send a special notice out to the CHIP folks to let them know how their premiums will start back up, and one out to the emergency Medicaid folks to let them know how will they be treated, what does it mean for them specifically. So a lot of where we thought a message was appropriate to a group, we've tried to really carve that out and focus on that. But again, the biggest message is that general notice, and when folks see that, they'll understand that that's hopefully they'll see that that's coming from Medicaid and pay attention to that one. From that point on, once the 60 days hits, we really need people paying attention to what they're receiving from workforce services. Right now, it could be that they're, I don't know what they're using those papers for. They might be using it for many things. But it really will truly matter once that 60-day notification hits. Reading those notices, understanding what's being asked of them will be crucial. And working very closely with workforce services to make sure that's occurring.
Thanks, Jeff. I guess, so what is the process for like whenever any of these notices go out to just like put in a little small flyer brochure or something that just says like, please continue getting health care. Here are some basic primary care things that you might want to look at. Like, I just feel like while people are covered, like especially for those that might become uninsured or underly insured or just like insured in a way that isn't as good, I mean, I just have been telling people like, please go and get the healthcare that you need. It's sad that people have been putting it off for so long. So that's what I've been saying, but I think that they're confused because understandably, I guess that's just not what they've been. They get a little confused when they do call. And so I do know some people who've gotten something in the mail, so they made a phone call and anyway, I guess whenever I told them like, just go get the healthcare you need, that was like the most clear that they needed to be told. Like that is what Medicaid is to them, right? And so it's like, that's what they need to do is like, go get the healthcare and not put it off. But when I hear that people are like not getting tests that their doctor ordered because they're afraid of being back charged or held legally, they're afraid of this scenario that they would be held liable for the cost of that test because they didn't pay their premium that month. Because before the pandemic, if they didn't pay their premium, they didn't get health care coverage that month. And so they aren't getting health care coverage because they didn't pay their premium that month. And so that's just like the situation that I've heard about from a couple people that I just thought if we could just put out messages of like, go get here are some ways they can do that. I don't know, just wondering if that's possible.
It's certainly possible, and I'm glad you're on the notice committee with us. That's going to help us to make sure we get the messaging right. One of the early pieces that y'all suggested that we do, which we've made those changes, is to let people know, hey, this is an informational notice versus one that you have to take action with, that kind of a thing. So I think we've made some good improvements already. As I thought through this, and as we shift to that question from keeping things up to date to when is my renewal coming up, we talk a lot about those that will come first in line, if you will, but there's some that will come at the end of that line. And what you're saying makes perfect sense. If your review is not going to be for another year once the public health emergency ends, you have plenty of time to continue to use those benefits that are available to you. So I think we need to work with you on what that messaging looks like as far as making that a stuffer or adding that to the letter. I think those are both options we can consider.
Thank you. But just so that I make sure that I understand, I mean, so even for people that are the first ones that are going to be talked to, but right now they still have healthcare coverage. So like getting treatment between now and like January, for example, would be like a good idea for people who are concerned about whether or not they're going to be able to afford their premiums next year, or whether they are going to be, their eligibility has changed, or they're worried about whether they're going to get their paperwork turned in. Like those people that might fall off should get healthcare right now. right? Like, I mean, everybody should, that if they need it,
Right.
like get the health care that they need. But like primary care, like those basic things, like doing what the doctor's asking you to do, like those things should be done because right now they're covered, right? So it's like regardless of where they fall in the like schedule of when they're going to be audited, like they have coverage right now, everybody that is enrolled, correct?
Yeah, it's a very good point. And where this notice won't go out till that 60-day notification occurs, I don't have a natural place to put a notice today, but there are some places we could put messages like that. Workforce Services has a place like that on their site. We have a place on our site. And now that we have a dedicated page to this, I think it's a great frequently asked question we should add to our list of questions. So I think there are some places we can put that. But as far as a letter goes, there won't be any more letters coming out from DHHS until such time that we hear the 60-day notification. And we can include the message there too. But I think you're asking more like right now, like what do we do right now? And I think that's probably the same message in a different place.
Gotcha. Okay, thank you.
Mm-hmm. Let's jump into the case report. So I will scroll down a little bit there, if you will, to the very, very small print of all these little tiny numbers. We're on the third line there of the gray boxes, if you will. And this was included in the minutes and agenda if you got that from the meeting today. This is the current counts of where we are for the month of July. What we're seeing in the month of July is interesting. Across the board, even though some groups are still increasing, you're seeing that the numbers are decreasing overall. And that tends to mean that we have some kind of a glitch in the reporting. However, having recently talked with Select Health, we do understand that they have seen the drop off in CHIP, which is on the bottom of that line down there. Hard to see, maybe 761 are the number of children. If you can make that any bigger at all, I don't know if you can, Sharon. If you can, thank you. The CHIP numbers did decrease in the month of July by 761. It's a bit of an oddity. If you look at the history of CHIP over the last 12 months, you'll see that we were roughly losing between 250, roughly about 250 each and every month, a little higher, a little lower in some months. And then in the month of June, we still lost, but we lost 6 children. That's unusual. Then we saw a very large dip here in the month of July. Some of that may normalize as the reporting goes. That may be a hiccup in that way, or it may be that there are more reviews done in the month of June or July. And so I asked Maurice to take a look at that. I'll kick it to you, Maurice, if you found anything.
Sure. Yes. So I did have about an hour head notice before I started embarking in this research. So I do apologize for it not being fully complete, but I do have some information to share. Yes, we did have a larger number of reviews in the month of July that have caused the issue that we're seeing. To Jeff's point, the July data has not fully settled until the end of August. So some of these cases are getting reopened as we speak, and as customers kind of participate with the review and complete the eligibility requirements. One thing that I have found is that the majority of the closures that have occurred due to the fact that customers have not completed reviews. So out of the reviews that we've sent out, roughly about half of these closures are due to the fact that customers have not completed the reviews, and another third was for income exceeding limits. Those were the 2 biggest reasons. I have researched possible systemic glitches, and I have researched some operational difficulties that we may have had, and nothing there indicates anything that might trigger the response or the connection to reduction of CHIP numbers. But that's as far as I have gotten, Jeff and others. It'll be exciting to see what this report says and how many of these cases end up getting reopened, but we are seeing some of them coming back.
And if I could just add to that, Maurice, when we looked at the closure reasons for CHIP, one thing that was interesting to me, looking at 2 closure reasons in particular, one was income exceeds limits. The other was those cases moving back to Medicaid. It was about a 3-to-1 difference, meaning that for every 3 that went for income being too high, meaning they're leaving the program, about 1 was going back to the Medicaid. So in both those cases, they lose the CHIP coverage, but Medicaid is not gaining that corresponding uptick. It's several were leaving the program. And that, at least for me, knowing where we are with inflation, et cetera, but the job market is good, and I think that's having some impact, and that does have impacted CHIP. What we should also be seeing right now is a large influx of children moving from Medicaid to CHIP, and that obviously cannot occur, which would probably offset this in most normal times when the economy is doing well. I think there's a question there from Jesse.
Yeah, Martha, I was curious, is that 50% usual in terms of why people are leaving for not completing their review?
We've been tracking this for a while, Jesse, and I think this is a trend that we've been interested in for the course of the years. If memory serves, and Jeff will remember this as well, most of the time, when we look at chip reviews that we're receiving, we have about a 40% non-completion rate on our reviews. It ranges anywhere from 33 to 40% in any given month. That's what we've seen in terms of customers not completing their reviews.
I mean, I'm wondering too, because at the CHIP Advisory Committee in July, we talked about how call wait time seemed a little bit higher than usual. And so I'm wondering, could that also be contributing it to the people are trying to call in and have you, I'm just flagging that as a concern. And I'm wondering if there's any updates on the call wait times. I know Sarah Lethem was the one who brought that up here, but or she brought that up at the CHIP Advisory Committee, but
yes.
Are there any updates around that piece too?
Yeah, I'd love to comment on that. As you see the increase in numbers, our staffing levels remain the same. So as a result, we get more cases to process and, of course, more phone calls to answer. We have embarked in a different resolution to this. What we believe we should provide is maybe a superior product to the one that we currently offer on our MyCase portal. So I'll give you a couple of examples. Currently, if you get on MyCase, and this is something I've engaged in the last several months, just kind of doing an evaluation of a product that's now 12 years old. The navigation is cumbersome. You can open MyCase on a phone and a mobile device. However, that navigation is cumbersome. You have to resize, you have to scroll left and right, up and down. We have been working on a deployment of an upgraded MyCase product that's launching in the month of January, which possibly could line up with the end of the PHE as well. It was scheduled originally for August, but there were a couple of other elements that we were still putting into the system. So we decided to move that complete release in the month of January. I believe the path to us getting to the point where we do a better job on our phone calls is to creating another avenue that is convenient and fast for customers to look up, so they would resort to doing that versus making phone calls. Because the overreaction to phone calls, usually if the call wait times go up, and from the community is like, put more folks on the phones. But that's exactly opposite to what we should be doing, because we should be focusing on processing, so there's no need for the phone call to happen. So that's kind of that's the direction that we're heading in. We are still offering callbacks to customers. So if our estimated call wait time is more than 45 minutes, we allow the customer the option to just hang up, and they'll keep their place in line, and we will call them back. But yeah, we are still hovering on average call wait times within 15 minutes, although there are some hierarchies that get hit harder. For example, if we have an issuance glitch of some sort, or customers are worried about their maximum allotment or anything else like that happening, we see an increase in the phone calls and corresponding call wait times.
Brian, I see your thanks for that, Maurice.
Yeah.
Thanks, and thanks for doing the research, Maurice. You probably aren't doing anything on Medicaid yet. You're probably just looking at CHIP, but are you going to do any kind of look on Medicaid as well?
That is one that is difficult to do. If there's something specifically or an element of the population that you want me to look into, I'd be more than happy to do so.
Okay. Maybe I'll give you a call.
Yeah, please.
Thanks.
And I see Stephanie has a question in the chat, and Destiny has her hand raised. Maurice, do you know how many people utilize the callback feature?
That is not a measure I have on me. It is an option the customer can get into after the estimated call wait time is that large. Some do, some don't, and I can certainly get those numbers for you, perhaps report on this next time, but I do not have that number on me.
Okay. And Destiny has a question too.
Thanks, Jesse. Hey, I was just wondering, was there something that occurred with Medicaid members in July? We did notice a change in our membership numbers, about 5,000 less. I'm wondering if maybe you were starting to do reviews for Medicaid, or if there was, maybe something you could share with us that would have caused a decrease.
Jess, do you want me to attempt that, or do you want to?
Yeah, sure.
Okay. As it has been mentioned, we do our best to keep Medicaid cases open during the PHE. I think the population that you're referring to is, let me kind of back up a little bit. So our system right now does something called a reopen job. And that reopen job would potentially capture anybody that is scheduled to close for whatever reason outside of those three, and then reopens the Medicaid program for the time being. We have we have a group of folks that now does or has been doing for us manual reopening of those that do not get captured by that job. The population that you're talking about in size is similar to what we are getting every month, and we're manually reopening those. Usually customers that end up experiencing a closure end up getting reopened by the end of the following month.
And the Destiny, maybe to jump in on that, we are not reviewing Medicaid cases right now. That activity will not start until the PHE ends. So what Marissa's saying is correct, that we do have some number of cases that unfortunately, have to be manually reopened. That number also continues to grow each and every month, although I think DWS is fairly efficient at getting to those. But that wouldn't explain necessarily what you're seeing. I'm not sure it's the same population we're talking about, so that's interesting.
So they'll be corrected, maybe just have to be backdated, do you think?
Yeah.
Yes, that's what should occur,
Okay.
yes. And if you have
Okay.
examples where that's not happening, if you could share those with us, we'd be very interested in trying to track down what's going on there.
Okay, yeah, we'll let you know if we find any. Thank you.
Thank you.
Do members lose their referrals during those types of when that type of thing happens? I don't know if Destiny or if anybody else on the plan side of that knows that, or if y'all know that, but that before the PhD, that happened to me where I would lose referrals because they would say that my Medicaid ended, and it was just like a backlogged constant having to refix something. So anyway, I don't know if that's something that y'all have heard about in the plans of like people losing their appointments because of situations like that.
That doesn't happen with Premier Access for dental plans. They would still be valid for 6 months. They're valid for 6 months, any pre-authorization, or we don't require referrals, but like a pre-authorization is good for 6 months as long as they're eligible, on that date of service.
Gotcha. Okay. Do we know if like the examples that Jeff and Marissa just talked about are those examples where somebody might lose an appointment because they would have lost coverage in that, or it would have looked like they lost coverage for at least a moment in the system, or is that not how it actually happens?
I think you'd have to consider what happens kind of in the regular times and what's happening right now. I think most folks are aware that Medicaid is keeping cases open. If they see something like this, my guess is they might behave a little differently than they would in the normal times, knowing that the Medicaid case is most likely going to be reinstituted at some point, and coverage will continue unless the person's moved out of state or asked us to close their case. I mean, it's unusual that would occur. I think in normal times, I mean, the one thing the public health emergency has solved is churn. We don't see as many people churning on and off the program, right? I mean, that's the reality. But that will return to us once the public health emergency ends. And so you'll see people that when they don't complete the renewal, for example, the case will close. They might then later complete the renewal and the case will reopen. You'll see that kind of behavior come back, unfortunately. And in those times, it may make a little bit more of a difference in how those appointments are treated. But a provider would have to tell you if that's true.
Stephanie, let me just add to that as well. If one of your constituents has a concern and they have an appointment and they need to verify that their coverage is good, if they by some small chance find themselves on that population that is waiting to get their case reopened, by calling us, we can forward that case to the help desk and we can reopen it immediately. They do not have to wait for their place in line. So if they discover it, they need to contact us. We should be reopening those cases instantaneously.
I know we've gone a little bit over our time, so I probably will kick it back to you, Jesse, unless you want to discuss further.
No, thank you for that. That's helpful. And, I'm thinking too, in addition to the callback, I just wonder, to your point, Maurice, around phone calls versus like that. I'm excited about the My Case app to be updated, but, there is still, I just wonder how many people know what, use the My Case versus prefer to make phone calls. I wonder if there's any metrics we can look into that, or if there's been any surveys done of Medicaid members. So I'm just throwing those ideas out there, but
I do not have those metrics for Medicaid population specifically. We look at our population as a whole. Roughly two-thirds of our population utilize My Case, and that similar number submits their application online through a My Case portal.
Thanks. Okay. Well, thank you. Thanks for that information. Appreciate it. And so now we'll turn over to Jen with the updates on school-based skills program, and then you can also just go right into the director's report too. Sorry, we kind of didn't give you as much time, but I think it's been a really helpful discussion today. So thanks everybody for the discussions and input.
Thank you, Jesse. And I'm actually going to have Eric Grant present on the school-based skills program update, and then I'll move into the director's report.
Okay, just to let everybody know, members of the committee, we have changed our methodology in the last year for state fiscal year 2022 of how we're reimbursing the school districts for the school-based skills development program. Basically, we've looked at what other states are doing, and along with guidance from the federal government, we've switched to a random time moment study methodology for reimbursing them, which basically accounts more for their cost of delivering services rather than based on the specific services they're delivering and a procedure code based price per procedure. So we're actually considering their cost, and then they're subject to this random moment time striking system where they will have to go in, the participants in the district will have to go in at certain times and document what service they're performing at that time and for which type of student. We feel that this is a better way to reimburse the districts. They have had kind of mixed reviews on it, but the more we've gone along, they seem to be more in tune and in touch with it and are starting to like this new methodology. Ultimately, in the long run, we feel this is going to yield a better result and get them reimbursed more realistically towards their cost rather than a fee-for-service basis. So any questions on that change? Okay, I'm going to give it back over to Jen.
Okay, thank you, Eric. And I'm going to share my screen here for just a moment to go through the update report. And due to time, I will jump through a few items that are a bit of a review from what we addressed last meeting. Let me make this just a touch bigger for you. So wanted to just update you. I think we kind of cover for the past couple meetings, at least an update on House Bill 413, our Medicaid amendments update. This is our working group that is looking at an integrated model for our TAM members. What we wanted to just update you with is that we have had subgroup meetings to evaluate different types of models and evaluate different pieces of this model. And we are going to take that subgroup analysis and bring it back into the central larger working group this week. And this meeting is tomorrow, the 19th, where we will have our subgroups present their recommendations and their evaluations, as well as then have working group members dialogue about this. So we're looking forward to moving forward with that conversation. I mentioned last time updates on PRISM. There really are no large updates on our PRISM project at this time. Other than that, our staff are very, very engaged in finishing UAT testing of the platform to make sure our PRISM platform is functioning and working as it's intended to. Through testing, they're very engaged in developing our training materials, both for internal staff as well as our external provider partners. So we have good resources and tools available. We did also have a statewide provider training this week. That is our general Medicaid statewide provider training that has been occurring over the last couple weeks. But this one specifically this week did look at PRISM and give a very high level overview of some of the changes that are occurring in the PRISM system. But we are moving into a more formal, outward-focused communication plan regarding PRISM changes directly to provider groups September. So we will be launching a general provider training then. We will also be putting up many of our training materials on our PRISM website so that they're accessible. These will be on demand. We will also have provider specific trainings and live group training for those that are interested in and need that. So we are going to be doing some provider group direct trainings, and we will have resources and tools available. There's also information on the freeze. We mentioned this before, that our system is planned to be shut down from December 13th to January 2nd to lift the data from our current system and move it into our new PRISM system. And we will have a lot of materials to support our stakeholders and providers to help you understand the impact of the freeze and how that may influence our operations. So lots more coming really next month. We'll be able to give you much more updates on our PRISM system as we move into our communication plan at that time. That will be external facing. Okay, I want to spend just a little bit of time on policy updates. And again, I'll go quickly here just for the sake of time. UTA has gone really well. We had quite a few calls early on as we transitioned from the paper card to the digital touch card. Till now, we're getting very few calls, really no member complaints at all with this. There are a few kinks we're working out, but otherwise it's been a very nice transition from a paper card process to the digital card process. I have a few RFPs listed here just for your visibility. Motive Care was awarded our NEMT RFP. I believe we will go live with that January 1st, and we are discussing the elements in our new contract that were brought to our attention and voiced as concerns through the MAC committee, those being trips to pharmacies, as well as that 3-day window to schedule a ride. So as we walk through contract negotiations for our new contract with them, we are discussing these points, and I'll make sure we update you on what that will look like. 2 other contracts or RFPs have been posted. Our managed care dental went up on the 15th of August, and our pharmacy point of sale, I believe, will be posted either today or tomorrow. You see the time frames that these are posted. Prior authorization updates. I went through these last month around removing PAs for both personal care services and our annual formula. Wanted to just touch on where we are with medical respite services. This is something that went through and was approved with legislative funding through our 2021 session. We are doing ongoing work with CMS to get our 1115 waiver approved for our medical respite services. Our RFP language is being drafted. We will bring you more detail of our medical respite offerings in the near future. Wanted to alert you to some changes September 1st. The hospice manual has been updated. All of that content, mostly it's reformatting, very little policy change other than allowing physician assistants to be attending physicians for hospice. There will be more policy change for hospital coming in January when our PRISM system goes live. But for now, it's mostly a reformatting and moving what was in rule into our manual to allow a little bit more flexibility with just some small operational elements of hospice. We did open some codes to cover monkeypox and the public health emergency that was announced last week. We opened 2 codes for vaccines that are listed here, as well as a laboratory test for that. That service is open on both the CHIP side as well as our Medicaid population as well. Last one thing I wanted you on was just for your awareness, we will bring you more information, is that we have been working on our autism spectrum disorders services manual. And we have our policy updates drafted. They are being sent out for stakeholder review. We will make sure you see those as we move through the process on some of our updates on our autism services manual, our policy. This is slated potentially for end of year 2022. So is our time frame for some of those. So we will bring that to you as it moves a little bit further through the policy development process. I'll highlight, we were interim session this week. Just wanted to give you just a little bit of awareness of what some of the topics that were covered that did touch on what the Division of Integrated Healthcare is working on and Medicaid activities. And then last, we are working on a new Medicaid card design. So we have a really nice DHHS card design that reflects our new department, as well as the colors and the logos. So we will bring that to you. There's more to come on this as we develop this and are ready to bring it forward to you. So I'll take any questions you may have now, but sorry to rush through that so quickly.
And I can follow up with you really quickly after, but I have heard some feedback about the cards recently, and just the impact of not getting a paper card in the month, every month in the mail. So I'll follow up with you, but that might be something I just wanted to flag. So you'll get,
Thank you, Jessie.
Thanks. Great. Well, thank you so much for going through all of that, and appreciate the updates that you share every month and just we'll share that out afterwards too. So I think that's been really helpful. So with that, I just want to mention that Michael Hales will be the new chair. We have a new executive committee. Jennifer Marchant will be the vice chair, and then will become the chair. And then we have a new member at large, Joey Hanna from the Utah Parent Center, who's been on this committee for several years as well. And so thank you to the new committee. And again, thank you so much to Stephanie for being the member at large and the part of the executive committee for these past 2 years. They've really blown by. So thank you so much for everything you've done, and welcome new executive committee. Michael, I don't know if you want to say any words, or here's a little baton that I can pass to you.
Well, yes, I know everybody's jumping off, but Jessie, thank you for your service as the chair and formerly as vice chair on the committee, and all of your 6 years in total of service. And it's been great to work with you for the past 2 years. And Stephanie, also thank you for your service. So we'll look forward to your continued involvement, and take a new set of MAC executive committee starting next month. So we'll look forward to that and working with the rest of the committee going forward. Thank you.
Thanks, Michael. And Christine, same to you. It's been such a great, I've enjoyed being able to work with you for these 6 years, and I'm sure we'll stay connected as well. But thank you so much for being on the MAC as well. I'm going to miss you. And yeah, with that, thank you, everybody. Enjoy the final weeks of summer, and we'll see you all in September. So thanks again, and thanks for all that you do. Bye.
Thank you.
All right.